Any queries or shall we move forward? Okay, now let's move forward. Now this is a bite registration. The same putty you loaded onto the occlusal surfaces of the teeth. You ask the patient to bite, you wait for the setting, and the bite registration is ready. Now the two most common radiographs which are required, one is the OPG, panoramic view, which gives us the details of all teeth present, the status of the third molars, their which stage of eruption, any periapical abscess, any supernumerator, any impactions, or any dilacerations, and so on. And again, lateral step is important for all the radiographic values, all the skeletal, vertical and soft tissue profile values. Now the pictures. Now what pictures we needed from the doctors are the four external pictures. One is the external in the frontal view at rest, frontal view on smile, profile view that's at 90 degrees, and then the oblique or three-quarter view at the 45 degrees. We need these five intraoral pictures, upper and lower occlusal views, right and left lateral views, and the frontal view. And mostly in the lateral views, it's better to capture the canine and the molar relations as well at 90 degrees. Okay, so this is the ClearPath diagnostic form which will be supplied to you doctors by a regional team, which includes all the biodata, history of patients, number of teeth present, what plan you want, any special instructions, and so on. And we emphasize that it should be filled in complete detail by the doctors so that can make us easy for the fabrication and manufacturing. In case if the doctor is stuck somewhere in the treatment plan, so we can also guide you with that. Okay. Now these are certain cases to discuss and share with you. Single arch cases. Okay, we also deal with a single arch case. Suppose in this the upper arch is being treated. You can see there is around 5 millimeters of crowding in the upper arch. It is treated by arch expansion and all the teeth they have been aligned. Another case of arch expansion. You will see the spaces in the lower arch, possibility there was a mesodense supernumerator was there, which was extracted. And now the patient is asking for the closure or consolidation of these spaces in the lower arch. And this is how the spaces are being closed. Okay. Aligners, sir? Yeah, we can. Most widely we do this. No, we do dental extension. Skeletal extension is not this. Yeah, it can be done if you doctors want it can. Yeah, suppose that the lower are blocked out with it. Of course, it cannot be treated with aligner. So lower we can go for fixed and upper one we can give you the removable aligner.
So one more thing is ischema closure. Up to what size of a ischema can be easily closed with a aligner?
4 to 5 millimeters. Okay. Now the IPR, that is the interproximal reduction cases. And this is crowding in the upper arch as well as the crowding in the lower arch. They have been treated with the IPR. Okay. Again, another case of IPR with the crowded upper and lower arch. And you will see before and after. Okay. So this was the progress of the case. Step by step. This is how we get the aligners. We incorporate the movement in each and every step. Very light continuous forces. Okay. Another case of the IPR. Before and after. Yes, please. It can be decided by you. That's the first priority. Now, if the dentist says he or she cannot decide, so we are always there to help you. And we can guide you accordingly. Okay? I'm coming to that point. I'm explaining very intensively on this IPR in the upcoming slides. Okay. Now, this is another expansion case. You can see the crowding. And that has been treated with this expansion. Okay. No. No. This side we have the posterior region, but we have worked on the anterior region. In these cases where there is any bridge of prosthesis, we work onto the anterior region. Okay? We can also give the sectional aligners just from canine to canine or 3 to 3. Yeah, because you know the crowns के shoes होते हैं, they will result in ankylosis. So it's better not to touch that prosthesis part. Sometimes we also try to skip that. Yeah, we can give a try. मगर उसमें थोड़ी सी difficulty होती है. There are certain limitations, but if we can do, we go for that. अच्छा, it also depends कि आप crown ऐसे लगाया हुआ है, इसके endo हुई है, plus endo की condition क्या है. ठीक है, you know what the quackery की malpractice होती है, the endo have not been done correctly, उसका GP point कहीं और जा रहा होता है, access cavity is not prepared properly, so we have to see that. If that is the condition, so that's again a limitation. We cannot treat, we cannot move that endo treated because उसमें failure of endodontic के chances ज़्यादा हो सकते हैं. So we have to see कि उसकी prognosis क्या है. If it's good with the endo and everything and it's perfect, then we go for the movement. It again depends on the rate. If it's completely failure, the chances कितना? There is not a contraindication. We can go for this. Again, depending on the factors के people हुआ कैसे endo. Okay, if the endo is done perfectly, then we can go. Okay. Another case of the arch expansion, the upper arch after treatment and the lower arch after treatment. Okay. Now this was the case in which you can see the spaces in the upper arch. Okay. Here the space has been created for the insertion of prosthesis as demanded by the dentist. So we have left the space over here for the insertion of implants after the treatment. Okay, so this was the progress of this case. Okay, now the crossbite case. This tooth and this tooth is in the crossbite and that has been corrected by elastic button technique. Elastic button technique, जैसे हम fixed ortho में elastics insert करते हैं from the upper palatal aspect to the lower buccal aspect, exactly the same way we also insert these elastics in the aligners. Another crossbite case. It has again treated by the elastic button technique. So before and after. Actually for that in the aligners we insert the cuts and slit outs. ठीक है, हम बटन के लिए कट बना देते हैं जहाँ से कुछ surface is visible. So on that part you can insert the button. ठीक है, और upper arch में we give a hook-like structure in the aligners that's known as a slit. जहाँ से आप elastic button insert करते हैं. I have the picture in the upcoming slide that will make you more clear. जी.
क्या aligners में इतनी retention होती है कि वो elastic जो है उसको straight करते हैं?
Yeah, and we also give attachments for the retention. If we think the retention इतनी नहीं है, so we also give attachments. ठीक है?
Different kind of retention देनी पड़ेगी मेरे spacing वाला case का.
Sorry, different में?
Retention देनी पड़ेगी अगर space को दिया.
हाँ, it depends. अगर आपने बहुत wide space दी है, that's different. Yeah, usually fixed retention is indicated for the diastema. But again, it depends कि कितना diastema था, आपने frenectomy की है या नहीं की है. ठीक है, yes please.
मतलब एक केस है जिसमें क्राउडिंग है और एक पैलेटरी पड़ा हुआ है, एक तो पड़ा हुआ है, 2 पैलेटरी पड़ा हुआ है और 1 और 3 जो है वो क्लोज स्पेस को क्लोज कर दिया, क्राउडिंग हो गई है वो. तो उनको जैसे हम जनरली ऑर्थो में ओपन कॉइल स्प्रिंग्स वाल उसमें कैसे करेंगे?
अगर that's a blocked out tooth, so that's a limitation with the line. As I mentioned in the limitation, the blocked out teeth they cannot be treated with the line.
Okay.
Another case for the crossbite. You can see the crossbite over here. The tooth is palatally displaced, but see here we have space. can give the aligners. But if there is no space, extraction that space banana, if there's a block out there, then that's a limitation to the liner. But here you can see, we can easily move the tooth into the order and have space. Again, another case of cross pipe. You can see. And that's treated with the liners. Okay, now the lower incisor extraction cases. Okay, now you see that there is severe crowding in the lower arch. Okay, and in that case, a single lower incisor extraction is recommended. So these cases are also very well treated with the liners. The lower incisor extraction cases in all the different views. Now the Pontic case. The Pontics can also be done with these aligners. Okay, suppose the patient has gone for some sort of extraction and the prosthesis cannot be inserted immediately and patient has to attend any socially sensitive occasion or anything. So we can also insert a Pontic and we can place. So that's really pleasant aesthetically. So these are the different case reports which have been published. As a treatment of bimaxillary protrusion using the first three molars, extraction with clear path aligners. And these case reports have been published both nationally and internationally. Correction of anterior crowding by the clear path. Treatment of crowding with the clear path aligners. Case study of the treatment of spacing with the clear path aligners after the implant therapy. Okay, so it's very important to first begin with the simple cases so that you can get the entire knowledge and you can bring that into the practice, because once you apply it into the practice, samajhne mein aur karne mein there is vast difference. So it's better to first start with the simple cases. Okay? So now let's move on to the brainstorming exercise. Sorry? Yeah, they are upcoming slides now moving the comment. Okay? Abhi right now let's have a brainstorming activity. You all have your handbags. Okay? Isme there is an activity for you. Can you please take that out? You have 5 minutes. In the first activity, you have to sort out the faults in the impressions. So what faults you see in the impressions, and in the second activity there is a case in which you have to do the treatment planning. Not in this. There is another. Have you found this activity?
Yes, separate because
Yeah, like this. So you have 5 minutes for this. You have to sort out the faults in the impression, and the second activity you have to just make the rough or a tentative treatment plan. Okay, 1 minute more. Okay, so have you people done? I hope so, the time is enough. Can we move on? Okay. So first quality impression. Yes, Dr. Umar, what do you think? What's the fault in this? Sorry?
Margins not taken properly.
Margins not taken properly. Anyone else? You can see the voids and air bubble. Basically, you can see the porous space. Okay? That's not an accurate impression. It's not fine in detail for the fabrication of alignment. Next.
7 is not visible.
And inadequate occlusion morphology. You see the second molars, they have not been captured properly. This one?
Improper application.
Yeah, improper application of adhesive. Remember, we have to apply the adhesive for the proper bonding between the light body and heavy body. So it's not properly applied, so you get a detachment. Here,
Labial fence is not.
you can see the tray, the visible tray from the margins. So excessive pressure has been applied on the application of the trays into the patient's mouth. I hope this is clear. Okay. Now, the treatment planning part. Yes.
Upper 4-4 expression.
Yes, please.
Upper 4-4 expression. And lateral line.
Okay, anybody else?
Diastema closure. Posterior expansion of the region.
And lower?
Non-extraction.
Exactly. Basically, a slight arch expansion in the upper arch and IPR in the lower arch. We will treat it non-extraction, but again, you can have multiple plans. I'll remind this. Okay? There can be multiple plans. But the most appropriate for the alignment fabrication is the arch expansion in the upper arch, followed by the IPR in the lower arch to relieve this crowding. Any confusions? Any worries? Okay, let's move on. So now, interproximal reduction. Many questions were even asked. Let's see what is interproximal reduction. Any idea? Anyone? Any guess? Any clues? What is interproximal reduction?
There is a relation of the proximal surfaces to the surface.
Exactly. So interproximal reduction is basically the